Hello, I'm Dr. Bill Shearer from Baylor College of Medicine in Houston. Today I'm interviewing Dr. Jolan Walter, who is an expert in immune deficiency. She is the director of the Immune Deficiency Clinic and Division at Massachusetts General Hospital. Recently, she's made an outstanding contribution to the literature dealing with autoimmunity and RAG1 deficiency. And we're delighted to have you here, Dr. Walter. Please explain what your paper is all about.
Thank you for the invitation. It's my pleasure to be here and share our findings with you. Our paper would like to highlight the importance of looking and seeking for RAG deficiency among patients with a new phenotype that is characterized by primarily autoimmunity and tendency for infections. And this phenotype has been described back in 2008, and since then we are seeing an expansion of the number of patients with the characteristic of autoimmune cytopenias, tendency for infections, and occasionally severe complications with certain viral disease such as varicella. And the paper is highlighting a family history of two children who have been struggling all their life up to 7 years of age with autoimmune complications and infection, and eventually it was found to have a RAG deficiency. What we would like to emphasize through this paper is that the population analysis showed that the frequency of this disease may be much higher than previously thought. We are estimating it around 1 to 6,000. This is an unexpected finding. A SCID phenotype in RAG deficiency is thought to be as frequent as 1 to 250,000.
You've told us now that there's an interface between immune deficiency and autoimmunity. How does the mechanism work for our audience?
We think that RAG deficiency used to cause a complete depletion of T cells and B cells, and therefore there was an impaired immune system and tendency for infections. But in these cases, RAG activity is only partially impaired, which actually generates T cells and B cells centrally, and then these T cells can go to the periphery. Unfortunately, secondary to the impaired activity of RAG, receptor editing is dysfunctional in the bone marrow, and the thymus is also not selecting for autoreactive T cells well. And that allows the leaking of both autoreactive T cells and B cells to the periphery. There are additional mechanisms in the periphery, including the regulatory T cell compartment impairment and increased BAFF levels, and that will also add to the impaired tolerance checkpoints. So we think that it is a very complex disease with multiple tolerance checkpoints being impaired, and eventually it will give the rise of autoreactive cells initially, and then eventually to autoimmunity.
Where do you suspect that this deficiency originates? Would it be in the thymus gland that these pathways are interrupted and intermingled in a way?
I think it's actually a multifactorial process. We know that the thymus is clearly abnormal. There are less thymic epithelial cells that would allow for the actual elimination of T cells that will recognize tissue-specific antigens. So the thymus is clearly an important point in elimination of the autoreactive cells. But our recent paper in Journal of Experimental Medicine in 2010 showed that also B-cell checkpoints, especially receptor editing, is extremely important in elimination of autoreactive B cells. So we think that there are multiple central checkpoints that are being involved in this process of generation of autoreactive cells.
Now, do these patients that you've described have any evidence of allergic disease?
We are not aware of any specific allergic disease, but we do know that patients who have immunodeficiency frequently have tendency for atopy, either with eczema or food allergies. The patients that we have followed and found so far did not have specific food allergies, asthma or eczema, but it's yet to become to understand whether it's going to be present or not.
So in projecting out to your clinical audience, now what recommendations would you make to have them be aware of the possibility of this new finding that you made?
I would like to make our clinicians aware of this disease and to look for primary immunodeficient cases among patients who only present with autoimmune complications initially, but then develop T-cell lymphopenia, and that disease is refractory to conventional treatment. Basically, any patient who have autoimmune cytopenias, who develop significant infections, complications with vaccination should be considered for an underlying primary immunodeficiency, and in our case, RAG deficiency.
And for our doctors, especially subspecialists in hematology, perhaps oncology, who may see these patients initially, how do you make them aware of your findings?
I generally educate our hematologists at Mass General Hospital about considering at least a lymphocyte subset in patients who are refractory to conventional treatment for autoimmune cytopenias. And we generally also recommend the testing of vaccine-specific titers or immunoglobulins. And I think following these results every year or so would maybe give the clinicians an idea how the patient's immune system is affected.
Now, what happened after treatments of these children, these two children that you're talking about?
Fortunately, the second child, who was 2-year-old, could actually be identified earlier and got early bone marrow transplantation. Her transplant did not engraft well, so she needed a second treatment, but she's doing well. The 7-year-old sibling had a much more difficult course up to 7 years of age. And secondary to her sister's diagnosis, she also received bone marrow transplantation and is doing well. And I would like to contrast this family to another study that we published at the Journal of Allergy and Clinical Immunology in 2013 about a family in Connecticut. This family had 2 children. One of them died at 4 years of age with severe autoimmune complications. And the sister was diagnosed with T-cell lymphopenia right at birth. Both of the patients had recombinant heterozygous mutations, and the second child received bone marrow transplantation at 2 months of age and is doing great. So I would like to just advocate for early detection of these patients, and hopefully with the introduction of newborn screening, it is going to be a much easier task for all of us.
What particularly would you recommend people pay attention to in the screening process, this newborn screening process, to help identify such a patient?
This patient who had T-cell lymphopenia also had poor T-cell proliferation studies, so it was not too hard to identify her as a possible candidate for an underlying SCID gene. I also will give later tomorrow I talk about this condition of T-cell lymphopenia and secondary follow-up for T-cell lymphopenia. And overall, I believe that these patients should be followed vigilantly every 6 months regarding their clinical history and immune system, immune phenotype, and hopefully that way we can find them in time.
Well, finally, in closing, you made a very important observation in terms of treatment. You discussed the outcome and the earlier treatment are the better, but in terms of the families that you dealt with, what support systems are there for people who are totally confused by all this elaborate immunology that you've discovered? But how do they group themselves together or support themselves?
This is a very difficult task to have for the families to understand the potential dangers of the disease, especially if the child is identified early with no obvious clinical symptoms. I did meet the family from Connecticut, and I think it was actually harder for them to deal with the course of their 4-year-old child who died, because they had no idea about what was causing her disease. Once the disease-causing mutation and the complexity of the disease was more clear to the clinicians and the family, they had a much better idea of what the plans are and where the family is heading. So I think giving the family an exact idea of what the child has was crucial in that process. And it is a hardship for any family to understand that their child is in danger when the child is relatively looking well. But the more newborn screening is widespread and allowed to come to the clinical front, I think people will be more comfortable with this screening method and the pluses and minuses. It's very hard for me to talk about it.
Well, congratulations on your upcoming paper, and I predict there'll be many, many more of these coming your way. Congratulations.
Thank you. Thank you so much.